So welcome everybody to Rochester Lifestyle Medicine Institute and the William J. Folletti Center for Lifestyle Medicine Grand Rounds. And it's great to have everybody here. I am Dr. Ted Barnett, President and founder of Rochester Lifestyle Medicine Institute. And it's so great to have our wonderful panelists and wonderful presenter here with us. Case study tonight is called Tweaking Lifestyle Medicine Recommendations for Crohn's Disease, a case study. And if you're interested in partnering with Rochester Lifestyle Medicine Institute to empower your patients, please check out our website. You can look at the online referral forms that are available on the website. We have several standardized programs to build motivation and competence in a socially supportive, interactive environment. Several of our programs are certified by the American College of Lifestyle Medicine. And just so you know, we're a nonprofit. My wife and I are full-time volunteers, but we do pay our staff. CME credits are available for most of our programs. If you do Jumpstarting Health, you can receive up between 10 and 24 CMEs. You get 10 CMEs just for attending the Jumpstart. There is a $49 license fee, but the CMEs themselves are free. The LIFT project also has a $49 license fee for healthcare professionals, and you will receive 10 CMEs for that as well. Please respect the privacy of the patient who's being presented. There's really it would be very hard to identify this person, but it would be possible if you really worked at it. So we ask that you please don't do that and that you limit your discussion with other healthcare professionals. Dr. Kerry Graff is our presenter tonight. She's board certified in both family and lifestyle medicine. She has practiced in primary care settings for over 26 years in the Finger Lakes area of upstate New York. After practicing a hybrid of primary care and lifestyle medicine for the past 10 years, she now devotes 100% of her time to practicing lifestyle medicine. She is currently at Love.Life Telehealth, and she's a graduate of the University of Pittsburgh School of Medicine and the University of Pittsburgh Medical Center, Shadyside Family Practice Residency. She obtained her certificate in plant-based nutrition from the T. Colin Campbell Center for Nutrition Studies and E. Cornell in 2014, and was one of the first 204 physicians to become board certified in lifestyle medicine in 2017. The first year this board certification was available. She spent the first half of her career treating patients how she was initially trained with pills and procedures and has devoted the second half of her career to helping patients reverse chronic disease with lifestyle changes instead. And our guest panelist tonight is Dr. Will Bulsiewicz, otherwise known as Dr. B. He's an award-winning gastroenterologist, internationally recognized gut health expert, and the New York Times bestselling author of Fiber Fueled and the Fiber Fueled Cookbook. He is adjunct assistant professor of medicine at the Emory School of Medicine. He strives to make gut health education accessible to the masses as the U.S. medical director of personalized nutrition company Zoe and chief medical officer of Methodology. He has authored more than 20 articles, published in peer-reviewed scientific journals, has given more than 40 presentations at national meetings, presented to Congress and the USDA, and has taught over 10,000 students how to heal and optimize their gut health. Our regular panelists tonight are Dr. Robert Breakey, who is board certified in family medicine and lifestyle medicine. He has been a family physician in Ann Arbor for almost 40 years and serves as the medical director for IHA's William J. Folletti Center for Lifestyle Medicine, as well as the chair of IHA's governing board. He is also on the board of directors for several national organizations, including the Plant-Based Nutrition Support Group, PPOD, and Rochester Lifestyle Medicine Institute. He has a special interest in employing lifestyle medicine approaches for disease reversal. Dr. Melissa Sundermann is board certified in internal medicine and lifestyle medicine. She has been practicing medicine for over 20 years and is transitioning to a lifestyle medicine concierge role in the near future. Her clinical interests include lifestyle medicine, plant-based nutrition, food as medicine, and sports nutrition. Known as Dr. Outdoors, she is an avid endurance athlete and is immersed in nature as often as possible. And then Dr. Susan Friedman is one of our case wranglers. She's board certified in geriatrics, internal medicine, and lifestyle medicine. Dr. Friedman is professor of medicine at the University of Rochester School of Medicine and Dentistry and founding director of lifestyle medicine at Highland Hospital's Department of Medicine. She is RLMI's director of clinical studies, a member of American College of Lifestyle Medicine's Lifestyle Medicine Economic Research Consortium, and fellow of the American College of Lifestyle Medicine. She's an author of more than 40 high-impact papers, which have been cited over 3,000 times. And then me, I'm board certified in lifestyle medicine, as well as diagnostic and interventional radiology, and I'm the founder and president of RLMI. I'm a fellow of the American College of Lifestyle Medicine and a former member of ACLM's board of directors and chair of ACLM's Type 2 Diabetes Remission Task Force. So without further ado, let us turn to our panelists. I will stop sharing, and there they are. You guys have all been seeing them, but I haven't. So welcome, Dr. Bulsiewicz, Dr. Graff, Dr. Sundermann, Dr. Breakey, and Dr. Graff. Would you like to please share your slides?
Okay. Hi. So this is a Crohn's disease case report. We're going to call this person RA. She's a 32-year-old white female. She's self-referred for a lifestyle medicine consultation, has a 15-year history of Crohn's disease due to, and she comes because she's continued to have abdominal pain and diarrhea despite management for, this entire time by GI and failure of multiple medications. She stated that she had about a 25% improvement on Entyvio, which is the most recent thing that she's tried, which was started about a year ago. She states Entyvio has worked better than anything else, but her GI doc wants her to try a different medication because she's only 25% better, which she's reluctant to do since she's seeing some improvement on the Entyvio, and she would like to try lifestyle add-on instead, which she heard about in social media. And her goals were really less abdominal pain, less diarrhea, and she wants to avoid further surgery. So her past medical history, Crohn's, she's got some anxiety and depression. Past surgical history, she had a partial colectomy at age 23 with removal of 1/3 of her large intestine. She had a perforation due to the Crohn's disease at that time. And then she had to have a section of her small intestine, about 8 centimeters, removed at age 27 due to a stricture and a small bowel obstruction. She reports that she has known residual strictures present in both small and large bowel, between 25 and 50% of the width of the bowel in both of those places. I did not see that report, and I actually don't know how they determined that she has those residual strictures. Family history: father with hypertension, hyperlipidemia, and rheumatoid arthritis. Mom with some anxiety and depression, and brother with hypothyroidism and celiac disease. So some significant autoimmune stuff in her family history. Her current medications, she's on a multivitamin in liquid form daily. She's on duloxetine 60 milligrams daily, and Entyvio 300 milligrams IV infusion every 8 weeks. And then she gets occasional prednisone pulses intermittently when she has really bad flares, but she doesn't think it helps very much. And last use was about 5 months prior to her first appointment with me. So, panelists, I'd like to ask you if there's anything in the history so far that gets your attention.
Dr. Bulsiewicz, what do you
Yeah,
think?
there's quite a bit. There's quite a bit here that I think is worthy of discussion. I mean, it's almost, if we could we go back to the first slide and perhaps I just kind of give some thoughts as we go through the information that we received.
Sure.
Yeah. So naturally, with a person who has Crohn's disease and they present with abdominal pain and diarrhea, the instinct of any clinician is to immediately imagine this has to be the Crohn's disease. But I think that it's important for us to pause that thought for a quick moment, particularly in the context of this person who has failed multiple medications and is now on Entyvio. And I'm sorry, my cat just walked into the room and is very jealous of talking to anyone else. So I think that we need to pause that thought just for a quick moment and not make that assumption and ask the question, could this be something else that's driving the diarrhea and the abdominal pain? And so what I would want to know, you know what, actually, if I could just take a quick second, I'll escort him out.
We love the cat. We love the cat. It's fine.
Okay.
Cat.
Oh, we love the cat.
Okay. All right. So things that I'm thinking about. We could actually go to the next slide.
We want to see the cat.
Come on over here, Noli. Everyone wants to see you. Okay, so a few things. So first of all, every person who has Crohn's disease or ulcerative colitis, they have irritable bowel syndrome. Irritable bowel syndrome is superimposed in 100% of cases. This is my cat Noli. So you have to think about when you have chronic diarrhea and abdominal pain, you have to think about the possibility of irritable bowel syndrome, and that may not be a flare of the Crohn's disease. So you have to keep that in mind. Now, next up, we have this partial colectomy at age 23 with removal of 1/3 of the large intestine due to a perforation. Now, Ted knows this. I'm going to assume that this was the cecum, which is the right colon, because this is the area that people are most likely to get a perforation because it's thin. The the colon is thin in this location. And it's simultaneously, there was no removal of small bowel, I don't believe here, but I guess the question would be, what was removed? Because if you're removing the right colon, which is about a third of the large intestine, then typically you're also simultaneously removing the terminal ileum, and then you're reconnecting the ileum to the colon. And because you're removing the terminal ileum, you can actually affect bile salt absorption. And then you could, as a result of this, get bile salt diarrhea. We call this bile salt enteropathy, or sometimes bile acid malabsorption, BAM, BAM. And that, by the way, is treated quite easily. If that would be just diarrhea, no pain, treated quite easily with bile salt binding agents, like cholestyramine would be an example. 8 centimeters of small intestine being removed is not enough to be short gut. So short gut is not a consideration. But recognizing that this is a person who's had multiple abdominal surgeries, also because they have strictures, you have to think about the possibility of small intestine bacterial overgrowth, which could cause both abdominal pain and diarrhea. Now, in terms of the diarrhea, it can be Crohn's disease as a result of a flare of Crohn's disease, like they have active inflammation. But it's also possible that this person has stricturing disease where they're basically getting like an obstructive effect, and the only stuff they can get through is the liquid. So it's almost like an overflow effect, and they would simultaneously have pain if that were to be the case. Now, on the next slide, I think we go through the family history. And we obviously have a family history of multiple autoimmune conditions here. So we have rheumatoid arthritis, we have celiac disease, we have hypothyroid. And the question is, could there be a superimposed second autoimmune disease? If you have one autoimmune disease, then you're more prone to having a second one. And so we would think about things that are autoimmune in nature and also can cause diarrhea and perhaps abdominal pain. So celiac disease would be one of them. And another one that I would add would be microscopic colitis, which is not just one condition, by the way. Microscopic colitis is 2 conditions typically, but nonetheless, microscopic colitis can cause diarrhea like this. So these are some of the things that I'm thinking about as a gastroenterologist. And I think that the key from my perspective is to, before making the assumption that this is the Crohn's disease, which can create serious issues when we're coming to questions of what do we do with this medication Entyvio. Before making that assumption, let's take a step back and ask the question, do we know what's actually causing the abdominal pain and the diarrhea before we move forward with this patient?
Oh, thank you for that, Dr. Bulsiewicz. Quick comments from Dr. Sundermann and Dr. Breakey. Dr. Sundermann, can you go first, please?
What he said. No.
Yeah, right.
I think the biggest thing is that I'm taking home as this gastroenterologist is clearly not Dr. B, and just in terms of not looking for really the causality is just assuming that it's Crohn's and doing medication after medication and not really getting to root cause, which we see so often in people who are not lifestyle medicine. So, and just looking at the duloxetine, which we know can cause some loose stools, does that have any kind of effect? And then I know Dr. Graff will get into it more, but just other lifestyle behaviors that could be influencing her gut health. Look at dietary patterns and that can be influencing that. So I know we'll get into that further. But again, my biggest take home is, a physician who is just, pill for an ill and just going to add more medications without looking for underlying root cause. I see that there is that autoimmune that's prevalent in the family history. So looking at a deeper dive into that and then trying to figure out really what is the cause of her diarrhea and abdominal pain other than Crohn's.
Yeah, and the thing is, Melissa, that I know we're here to talk about lifestyle medicine, but one of the major things that happens with these patients is that people often do make the assumption that this pain and diarrhea is a flare of their Crohn's disease, and then they go, oh, they must have failed their medicine. And then you move on to another medicine, and this creates very serious issues because actually the first medicine is the medicine that's most likely to be effective. And once you bail on the first medicine, typically you're sending these patients on sort of a spiral in a bad direction.
Interesting. Very interesting. Dr. Breakey.
Yes, clearly this person is inflamed. And I'm sure as we get into lifestyle, we'll see whether part of that's diet, lack of sleep, stress, other components. The anxiety, depression catches my attention also, and could be the same root cause of affecting the brain and chronic inflammation. It's affecting her balance there. or it could be reverse causation because she's health concerns, worry, multiple surgeries at a young age that she's feeling depressed and anxious. And then like Dr. B mentioned, I see the family history of celiac for the brother, and assuming that's not just gluten intolerance, but it's really genetic celiac, it raises a flag there to think what else could be contributing to this. So yes, thank you. Great case so far, Kerry. We look forward to hearing more.
Yeah. Dr. Graff, how did we
So
do?
the things that really stuck out to me were the autoimmune issue, the fact that she had been through multiple medications and she never really got very much better from any of them, and the fact that the prednisone didn't really do very much. It really made me think that there's something else going on, that this isn't just Crohn's. And then the first thing I thought of was, in addition to the celiac, I did ask her if she'd ever been tested. I didn't have all of her records when she saw me the first time, and she had had celiac testing done. However, her brother was older than she was. He presented in his teens, and the whole family basically was doing gluten-free. So when she started having symptoms a couple of years later, she was still eating a gluten-free diet. And so her testing was negative, but she was already gluten-free, which means that they could have missed it. So that was in my brain. And then I've had a couple of patients with nasty lymphocytic colitis from duloxetine. But it turns out that her diarrhea was way predated the duloxetine. Going on the duloxetine didn't seem to make that any worse, but that was definitely on my brain. I did not think about small bowel overgrowth, so it's good to know that. All right. So in looking at it from a lifestyle medicine lens, we look at the 6 pillars: the fingers, forks, feet, sleep, stress, and love. And if you've been on any of these with me before, you know that I always kind of start backwards with love. Because if the patient's there out of fear, we're not going to get very far for very long with making change. She loves her family. She's got an Australian Shepherd that she's fusses over and showed me lots of pictures of. He was adorable, and loves to be outside in nature. Stressors, her health. She's got some financial stress due to missing work regularly due to her GI issues. She actually had applied for disability and was denied. She lives independently, but her parents were currently helping her to pay her bills, which she felt really guilty about. So she was no longer following her gluten-free diet now that she no longer lived with her brother. So she manages stress by walking her dog and getting outside and yoga now and then. But she couldn't really do a lot of any of those because of her GI issues. She didn't walk very far because she didn't want to ever be very far from the bathroom. And then she would also binge on Netflix and scroll through social media. So some unhealthy coping mechanisms. Sleep was 9:30 to 7 a.m. Several times a week, she would wake up at least once during the night with diarrhea. So nighttime diarrhea. She always feels tired no matter how much sleep she's getting. She doesn't snore. Fingers, she doesn't smoke or use any drugs, but she does drink a few beers twice a week. She did not notice that drinking the beer seemed to make the diarrhea any worse. And feet, for physical activity, she's getting about 3,000 steps a day. She walks her dog. Basically, it's around the block. It's about 4 blocks altogether, but she's really limited for physical activity, not just because she doesn't want to be so far away from the bathroom, but physical activity would often kind of stimulate her to have a bowel movement. She does do her yoga at home, and that way if she ends up having to run, she's not interrupting. So she doesn't want to go to an actual class anywhere because she doesn't want to be away from home or need to get up in the middle of the class. For forks, we actually did a review of what she normally eats, and she actually has a very regimented diet that she eats pretty much the same things all the time. And this really got my attention. Breakfast was 2 scrambled eggs in butter, white toast with butter, and turkey sausage. Lunch was cottage cheese with peaches or tuna fish with mayo. Snack, she eats a lot of crackers and cheese in the afternoons because her lunch does not really hold her very long. So she eats multiple portions of crackers and cheese. And then dinner is almost always chicken, usually baked. There's some applesauce often. There's a baked white potato with butter and sour cream, or maybe a baked sweet potato or white rice. And about half the time, she will eat green beans if she cooks them really well. She tolerates them, but she puts butter on them. And if she does that, she doesn't do the applesauce. So, and then snack ice cream is 2 or 3 times a week. She'll have some ice cream in the evening before bed. So if you actually kind of put in kind of what portion she has of each of those things, and basically she's eating a 1.5 servings of fruit a day, about a half a serving of vegetables a day, no whole grains, no beans, and about a half of a potato on average a day, no walnuts or flax seeds. So those are all the whole plants she's getting, right? Is that, and then all of the non-whole plants that she's getting 2 eggs a day, 6 or 7 servings of dairy because of the butter she uses on everything. Meat and fish is 2.5 servings a day. She's getting 3 to 4 servings of processed foods in terms of most of that's crackers, but some white bread and some white rice. Oils about 1 to 2 tablespoons. She's drinking plenty of water to stay hydrated, so that's good. She does not drink any caffeine, and she does not eat out or get takeout very often at all. And I always do basically a percentage of your calories from whole plants, and I estimated that her percentage of calories from whole plants was about 10%. And because this is a GI case and because we have Dr. B with us, I counted up her weekly fiber sources because, Dr. B likes to tout about us getting 30 servings a week. So she was getting 5 applesauce, peaches, white potatoes, sweet potato, and green beans. And those were the only sources of fiber she would get in a week. She appeared fatigued, but she wasn't overly pale, and she's thin, but not emaciated looking. So, kind of a little sick, but not horrible. She's 5'5", 114 pounds, which puts her BMI on the low end at 19.0. Normal temp, blood pressure was 110/70, heart rate of 78, no TSATs of 98%. In terms of her labs, white blood cell count was normal at 10.1, hemoglobin is slightly low at 11.2, crit of 34, platelets 301. So her ferritin was a little low. Transferrin was a little high at 401. TIBCs were high at 479. B12 was good at 765. Folate was normal 11.2. Vitamin D was a little bit low at 20. And her cholesterol was good. So, if you're looking at what she's eating a lot of cholesterol containing foods with all the dairy and meat she's eating. And her father has high cholesterol, but she does not seem to have gotten a genetic predisposition to that because her total cholesterol was 164, triglycerides 78, HDL of 50, and LDL was 98. Her electrolytes, glucose, kidney, and liver panels were all in a normal range. So I'd like to ask the panelists what gets their attention now on any of that.
Dr. Bulsiewicz, you're up again.
Yeah, a few things. So first of all, low fiber diet. Not a surprise. This person has structuring disease. She's probably been scared away from fiber by her doctor. Second of all, I interpreted that as a quite high fat diet. And one thing that we do actually need to throw into our differential diagnosis now is exocrine pancreatic insufficiency. And the reason why is because EPI, exocrine pancreatic insufficiency, where the pancreas is not actually producing enough enzyme to digest your food, typically gets exposed when you're consuming an excessive amount of fat, and it can manifest with diarrhea. And it's more common in people that have inflammatory bowel disease. So anyway, that's something for us to consider. I want to go back to the symptom of having diarrhea at night, because I think that there's an important teaching point here for clinicians. This to me is a huge branch point in the way that I approach diarrhea as a gastroenterologist. This is one of the first questions that I'll ask a person who's having chronic diarrhea. Do you wake up at night to poop? And the reason why is because on one side is infectious and inflammatory causes, and on the other side are the functional causes, which include things like irritable bowel syndrome. You could have the most rip-roaring irritable bowel syndrome on the planet. It will not wake you up in the middle of the night to poop. Infectious and inflammatory causes are what wake people up to poop in the middle of the night. So it's something for us to be aware of. And again, this is a person with Crohn's disease. Perhaps that's the Crohn's, but also let's keep our mind open to the possibility of something else. And then the last thing, the labs. So the most striking thing to me, and I think the most important thing in the laboratory profile, was the iron deficiency anemia. So we have low ferritin, we have high TIBC, we have a low hemoglobin. I would assume that if we had the MCV, you would see a low MCV, like less than 70. And this can, of course, be related to her Crohn's disease that can drive that particular issue. But there are other causes of iron deficiency anemia. One of them can be colorectal cancer. Another can be celiac disease. When a person has celiac disease, they fail to absorb their iron. So, and then the last thing is the vitamin D. I think I'll just leave it at that. I'm sure there's other things to comment on.
Yeah, thanks for that summary. Dr. Breakey, your thoughts, please.
Of course, thinking outside, wow, thank you for a great GI review. Thinking outside the GI tract, another very common cause for iron deficiency anemia in women this age is excessive periods. Commonly the estrogen and dairy products for which she's consuming a lot may stimulate uterine growth and heavy periods. And I want to make sure to review that. Dr. Graff, you also mentioned a normal white count of 10.1. If you look at people on a true normal human diet, the white count ranges from 2.5 to 6.0. And most people are running at a very high level of inflammation. And the what seems like normal to us, because of course 10 is upper range of normal, is really a leukocytosis from chronic inflammation. And I'd be wondering about our other inflammatory markers that we commonly do a SED rate, but CRP and HSCRP might be helpful to just get a sense of how deep-seated this systemic inflammation is. But the biggest picture, I think, and I know Dr. B is going to get to this, is our clear microbiome dysbiosis with such a low fiber diet. And I'm estimating 10 grams on hers from the foods you mentioned. She's starving the microbiome, so they're literally eating away at the protective mucus layer and then continuing on from there on into the intestines, both large and small intestines. And again, I'll look forward to some of Dr. B's comments on that as we continue to go through. But thank you.
Yeah, no,
She
thanks for
actually
that.
was not having heavy periods. I didn't put that in the slides, but usually her periods were mostly regular. Occasionally she would skip, and they were light to moderate.
Mm-hmm. Dr. Sundermann, your thoughts?
So clearly, when Dr. Graff took a very thorough dietary history, and I quote this from Dr. B all the time, is that we want to advocate for eating the rainbow and trying to get at least 30 different plant varieties per week. Dr. Graff counted those up, and I think it was, 5 that she was getting. So gut microbiome. And Dr. B, I always envision the slide that you shared in one of your presentations. It's yellow, and you've got dysbiosis and all the disease states that dysbiosis can cause, and no pun intended, what came first, the chicken or the egg? But we clearly, with her dietary pattern and the lack of fiber, is promoting an unhealthy gut microbiome. And so now with this dysbiosis, and we go through those disease states that dysbiosis can lead to, on your list was Crohn's, was celiac, was irritable bowel. And so now it's just like, what came first? And, it sounds like she got a diagnosis of Crohn's disease pretty early in life, but now are we dealing with something else on top of that? I do agree with the presumably microcytic anemia, that celiac can cause that, looking at her dietary pattern, that she is consuming gluten and that consuming a lot of dairy. So is there some lactose intolerance going on as well?
Yeah, it's interesting. A quick comment on that. Crohn's disease and ulcerative colitis are essentially the model for dysbiosis, and my mentor at the University of North Carolina, his name is Balfour Sarter, and any gastroenterologist knows who Balfour Sarter is because he's one of the leading he's one of the thought leaders when it comes to the space. He has Crohn's disease himself, and he has shifted where he no longer refers to these conditions, Crohn's and ulcerative colitis, as autoimmune. If they were autoimmune, the immune system would actually be attacking the body, and there would be an antibody for that. It's not. The immune system is actually attacking the microbiome. And so the body is actually rejecting the microbes, and that's what's actually happening in these conditions.
Interesting. Wow. All right. This is fascinating. Dr. Graff, would you like to proceed, please?
Sure. So we've got a poll, and I didn't ask whether we have the poll to actually put out to all of the folks. Do we have that?
Yes, we do.
About Frankie?
Yes, we do.
Oh,
Okay,
excellent.
great. So what would everybody who's on the call tonight, what would you have her do next? A, start daily ferrous sulfate 325 and vitamin D 2,000 unit capsules. B, stop all dairy products. C, stop the beer. D, B, and C, E, all of the above.
There we go. So if everybody could quickly answer that, so we can see what the results are. Don't spend too much time on this. Bob, what's the result here? All right, Dr. Graff, do you want to talk? Actually, let's have Dr. Bulsiewicz talk about this, please.
Sure. So, I mean, I think that the laboratory panel made it clear. I think with iron deficiency, I've been trained to first ask why. I'm glad that we brought up the menstrual cycle. I forgot that she's 32, but the reason why, in a way, also is that this can be an early indicator of colorectal cancer and potentially life-saving for people where you detect it on that account. So, nonetheless, I do agree, though, that we should be starting iron supplementation and vitamin D in this patient. And I want to point out, by the way, that there's been a nice discussion from Patricia, who seems to also be a gastroenterologist, in the chat, talking about the benefits of vitamin D supplementation. So for people who are not GI doctors, we have found that people who have low vitamin D levels with Crohn's disease are more likely to have flares and more likely to fall out of remission. And this was initially association studies, but actually the game changed with the studies that are being shared in the chat, because although these were small studies, this is where for the first time they showed that supplementation could actually reduce the likelihood of flares. So anyway, vitamin D supplementation for this patient would be completely appropriate. Lactose intolerance could certainly cause diarrhea and crampy abdominal pain, so it would be appropriate to stop the dairy products. And I certainly don't want my Crohn's patients drinking beer.
Dr.
You have-
Graff.
do you have any issues with it being a vitamin D in a capsule versus tablets or drops? She's got strictures. So this was
Yeah.
kind of like my tricky question on there, was that I wouldn't have picked something that has a capsule in it because of her strictures.
I think that's a very valid point. That I actually didn't even consider that, but I think that recognizing the presence of strictures, I think you want something that's more readily absorbable.
I also, she was only a little bit iron deficient. It wasn't terrible, and she had very little intake, right? Because there's almost none in her diet. She's eating almost no green leafy things, and knowing that it might be difficult GI wise to tolerate ferrous sulfate in this person who's already got digestive issues, I decided not to. I decided to do well. I'll show you on the next slide what I decided to do. So let me close out of this poll.
Yeah, I agree with you. I'm not a huge fan of the ferrous sulfate myself. I've tended to use a plant-based iron replacement therapy. So like there's one that's called Plant Force by Gaia, and I've had good success with that.
I was just going to make her eat greens, but
That's cool.
looks like I can't advance because you're sharing still or something. So can you give it back to me?
Let's just hear if Dr. Sundermann or Dr. Breakey want to comment then.
Oh yeah. Okay.
I also picked B and C with concerns about iron potentially and trying to get it more from food sources. And I don't know, I'd wonder with Dr. B if vitamin D2, 50,000 units weekly is better, or is it better for the D3 over the counter?
That is a great question. This is not something I've spent time recently taking a look into. I recall vaguely from years ago a study looking at daily therapy as opposed to the 50,000 once weekly, and my recollection was that there was superior results with the daily therapy. But right now, I feel a little bit like I'm just saying that without the study to back it up. So I'm a little bit.
We'll get her some sunlight too.
Sounds good. Dr. Sundermann, any thoughts?
Yeah, I picked E as well. All of the above, and including stopping the beer with just if she does have some celiac and the yeast in the beer could be triggering that too. So
right.
I agree with everything that was said.
All right. So my initial lifestyle medicine action plan was to stop all dairy products, including all the butter, cheese, and ice cream she was eating. I did let her do some plant-based margarine and some plant-based ice creams if she wanted, just because I didn't feel like I could take everything away from her. She looked a little bit horrified. Stop the beer. This is a weird thing to put on the instructions, but I advised her to buy a high-speed blender. Because I was really kind of going more for the thinking about kind of using a lot of green smoothies as a way of trying to get some nutrition into her, but in a way that wouldn't clog her pipes and that she'd be able to handle okay without the amount of fiber. And then the plan was to substitute a big green smoothie for her usual breakfast. and to use spinach, peaches, and almond milk in that. And then she could add some peanut butter, especially if she was losing weight. So, because you remember she's on the thin side, so I'm taking out a big chunk of her calories with removing the dairy products. And I wanted to make sure she wasn't losing weight. The plan was to switch her lunches to either a pureed sweet potato or butternut squash soup, both vegan forms of that. And then the plan initially was to continue with her crackers, but without the cheese for snacks. Continue her chicken for dinner for now, but to eat green beans or well sauteed greens every night, along with the applesauce, trying to get more green stuff in her for the iron. Get blood drawn for a celiac panel, looking for antibodies because I was concerned about her testing being done while she wasn't actually eating any gluten. And start vitamin D liquid drops, 5,000 units daily. So 2,000 would be what I would do to maintain somebody, but if I were trying to catch somebody up, I would give them a higher dose, and I wanted to use the drops rather than the capsules. And then, she actually enjoys doing her gentle yoga, and just kind of having a set stress reduction plan that's built into her day every day instead of waiting for her to start getting stressed, to maybe help with some of the stress issues with that. So after a week after the initial visits, her labs came back and it was positive for antibodies for celiac disease. So I notified her of those results via the patient portal and asked her to stop all gluten-containing foods. So she had to eliminate the white bread and crackers too. She actually returned my message wanting to know if this was actually, like, if that could really be the problem, because just getting rid of the dairy and stopping the beer, the things that we had done already, her diarrhea and urgency were already at least 60% better. So she was already markedly better than she'd been any time in the last 15 years in a week just by cutting out that dairy. And then so she did agree to get off the gluten-containing foods and batch bake some sweet potatoes to use for snacks in the afternoon in place of the crackers if needed. Now, obviously, we need to expand her diet more, but this was kind of the initial plan. And then she came back at a 4-week follow-up visit, and she was really happy. Markedly decreased diarrhea and abdominal pain, about 75% improved. She's not had any nighttime waking with the diarrhea. So the thought was that she wasn't sure whether the nights that she was having diarrhea or the nights that she ate ice cream, but in retrospect thinks that it might have been. She was having bowel movements 1 to 3 times a day, soft, but nothing was watery. She reports that she tried using nutritional yeast on white potatoes and she likes how that tasted. She reports significantly improved energy. Anxiety was much better, and thinking that it was mostly due to feeling like she could actually had control over her symptoms. She could get out and do things better. She was really also enjoying the daily yoga. She'd not missed any work since last seen, so that was really helpful too, because then she was less financially stressed. Her weight was holding at 114 pounds, so that was good. She really loved doing the smoothies in the morning. And she's walking her dog for 30 minutes twice a day, going a little bit further than just around the block, because she wasn't worried about having a bowel accident anymore. So all of that was really great. In terms of her diet, she's doing 2 fruits a day. I guess I screwed that up a little bit. 3 to 4 servings of veggies because she's doing 2 in the smoothie. She still wasn't eating any whole grains or any beans. She was eating more potatoes, 1 to 2 potatoes. The reason why I pushed up the potatoes initially was because she already knew she tolerated them, so she wasn't scared to death of them. So the idea was just kind of adding more of the things that you know that you already tolerate. She was doing a 1/3 cup of peanut butter in the smoothie a day in addition. So those are her whole plant servings, and then no eggs, no dairy. She's still eating meat or fish once a day with the chicken at dinner, still doing some processed foods with the white rice. Oil was about a tablespoon a day, still lots of water, no caffeine. So her whole food plant-based percentage went from 10% to about 70% of what she was eating. It's still pretty high in fat because all the peanut butter she's eating to make up for a lot of that. And then our weekly fiber sources, they had been 5, went up to 9 because she added spinach, kale, butternut squash, and peanut butter to her list. So still fairly limited diet, but at least it was better. And so this is a question for the audience again. What would you do at this point? A, discontinue the smoothies and transition to a gluten-free oatmeal for breakfast. B, get her off the chicken. C, stop the nutritional yeast. D, add brown rice. E, all of the above.
All right, everybody, let's quickly answer this if we can, so we can get back to our discussion.
There's no real one right answer here. I think you can argue anyway. So
Dr. Bulsiewicz, what do you think?
I mean, I think the distribution shows that there's a bit of a debate on the particular topic, and I think it's understandable, because you could make arguments for or against several of these choices. So I'm not eager to discontinue the smoothies, but I do understand that we do ultimately want to ramp up our fiber intake in this patient and to add whole grains, and that's where gluten-free oatmeal could potentially play a role. But I'm not eager to bail on the smoothies just yet. With regard to the chicken, I don't see the chicken as contributing to her, global health or reducing her likelihood of having a flare. That being said, I also recognize that she's a bit underweight, and making sure that she's getting an adequate amount of protein. To me, the chicken is a big goal, but are we there yet? Are we really ready to move on from that? I don't know if the answer is yes. In terms of stopping the nutritional yeast, I think that I would stop the nutritional yeast, and the reason why it's not completely verified and confirmed, but if you look at the antibody panels that are done for people that have Crohn's disease, one of the ones that can be positive is an anti-Saccharomyces antibody. Saccharomyces turns out to be the same yeast that you will find in this nutritional yeast, and so there is the concern that this could potentially be something that's triggering or activating the immune system. And then, I liked the fact that probably the most popular answer, or the most popular answer, was adding brown rice, because that's pretty low-hanging fruit. We have white rice, and we can convert that to brown rice, and we can deliver more whole grains in the process of doing that. So I do think that makes sense. And I guess what I come down to is, you can debate several of these. I think that adding brown rice makes sense. I would stop the nutritional yeast. Whether or not it's the right time to get her off the chicken is a question. And then, I would love to bring some gluten-free oats on board, but I just don't know if I wanted to stop the smoothie.
Right.
that was exactly what I thought. So
So
sorry, go ahead.
Dr. Graff, what did you end up recommending?
Stopping the nutritional yeast. That was the big thing that could have flared, could have made things worse. So eventually I'd like her off the chicken, but I don't want to pull that yet. Eventually I'd like to get her off some of the smoothies, but I still want her to I need to get a lot more greens in her. They're super anti-inflammatory, and it's a way of getting them in that you're not going to add, at least most people are not going to add greens to their oatmeal. And so the one thing I felt really sure about was stopping the nutritional yeast. So I'll show you what I did do in the next plan.
Yeah. So in the interest, go ahead.
I just want to give a quick comment. I'll try to make it super short, Ted. So first of all, Kerry, I loved the dietary progression that you did with this patient. I thought that was completely appropriate, starting off with really broken down processed foods like smoothies and pureed soups. I thought that was perfect, and I loved it. I just want to interject and say that that felt to me like it would be the second or the third visit, and perhaps that was in the timeline of things. But for me, the first visit, I would be so focused on what is going on with this abdominal pain and diarrhea. Is this a Crohn's flare? That I would need to sort that out first before I would actually initiate the dietary modifications. So I think that if this patient were coming to a gastroenterologist, more than likely we would do some initial testing, some of it non-invasive, but there's a high likelihood that we would need to scope this patient to figure out what's going on. And in the process of scoping them, we would definitely biopsy for celiac disease.
Interesting. In the interest of time, I'm just going to pass on our two panelists, if that's okay, unless you guys have something you really, really want to say. Dr. Sundermann, Dr. Breakey. Okay. All right.
Go ahead.
Let's in the interest of time, Dr. Graff, let's move on, please.
So the concept for the next action plan was to move to a diet that's less liquidy to help decrease the diarrhea, but not so much roughage that it might cause intestinal blockage, and also to increase overall variety of fiber sources. So she really liked the green smoothies. I didn't want to take that away from her, and it was also great about getting the greens in. So I just wanted her to mix up the fruit a little bit. So try it with some strawberries or some blueberries, just to add some other things into your smoothies. And then she was going to try small amounts of non-pureed veggie-based soups that are really well cooked with small chunks only, and include greens in the lunches too. And then increase the amount of those that she was eating as tolerated. in terms of portion size. And then if she's still tolerating that, add a few green lentils or a little bit of brown rice into the soups that she was making for lunch. And then I was leaving the chicken as is for dinner, but aim for 1 sweet potato daily. And if she's eating the sweet potato with her dinner, maybe leave out the white rice at dinner. If she's eating the sweet potato as a snack, then maybe leave the white rice in. So at her follow-up 4 weeks later, she was tolerating the blueberries and strawberries in the smoothie. She liked having more variety. She's still using greens and peanut butter in those most of the time. On her own, she tried some grapes and clementines, and she did really well with those, and she really liked them. So she's left those in her diet. She tried a raw apple. That was not good, but she's still eating the applesauce daily, and that's been okay. She's eating her veggie-based soups for lunches. She's tolerating those either with brown rice in it or with green lentils in it. And then getting an extra serving of greens in her soups most of the time as well. So usually she's got greens in her smoothie and some at lunch and some at dinner. Mostly doing sweet potatoes as a snack, but tried actually eating brown rice at dinner with the chicken, and she did fine with the brown rice. So the switching from the white rice to brown rice went fine. So that was good. In terms of forks, she's now up to 3 fruits a day, 4 to 5 veggies a day, about a half serving a day of whole grains, a half serving a day of beans, and potatoes still 1 to 2. Still getting that 3rd cup of peanut butter in her smoothie. She really likes the peanut butter. No eggs, no dairy, 1 serving of meat, which is chicken at dinner. Processed foods are down to a half and a day, which was white rice, but right before she saw me, she'd switched to brown rice. So that's pretty much was switched as well. A little bit of oil with her chicken still. Water was still, nice high intake there, no caffeine. And she's up to 80% whole food, plant-based diet. And our weekly fiber sources are up to 17 because we added blueberries, strawberries, grapes, clementines, carrots, which were in the soup that she's making, onions, lentils, and brown rice. She'd not tried garlic yet, but she did put onions in and they were okay. So, and then her next follow-up 6 weeks later, she's having soft form BMs 1 or 2 daily with almost no abdominal comfort. She almost never has diarrhea anymore. Her energy is much better. She's not missed any work. She's sure her weight is actually up a little bit, but it's holding. So she went up about 4 pounds. So she's at a healthier weight at 118. And then it's holding. So she's not continuing to gain. If she was, we'd tell her to cut back on the peanut butter a little bit. She really does not want to give up the chicken because what she was currently doing was working really well. She feels overall she's 90% improved from her baseline. And then she really expressed a lot of frustration that her gastroenterologist never suggested lifestyle medicine consult, and it only has offered her pills and surgeries. So yeah, I get that. I think that a lot of docs don't know, what we are and what we do and how we can augment what they're doing and can be helpful. The next lifestyle medicine action plan was to continue all the great stuff she was already doing. Use brown rice all the time instead of white rice, and she was tolerating that fine. Keep adding different vegetables into soups to increase variety with an eventual goal of trying to eat 30 different fiber-containing foods each week. But at least for now, make sure everything is in small pieces and very well cooked. I'm still really kind of paranoid about her strictures and whether we're going to pack a bunch of raw roughage through there and cause her to get impacted. I advised her to go slow, adding only 1 thing or making 1 change in her diet at a time. So if she did have a problem, she'd know what it was due to. Okay to try some gluten-free oatmeal, but still make sure to get greens in 2 daily at the other meals, just trying to get her a good iron source that is not so bothersome to the stomach if she was not doing the smoothie. And then that really kind of winds up the case. So does anybody else want to comment on anything before I go through the kind of like final learning points from the case?
Yeah, let's hear from the panelists. So Dr. Bulsiewicz.
Yeah, we just point out, Bob wanted to talk about the microbiome, and this is where we talk about it, because the 2 slides ago where you said that her bowel movements are now formed and excellent. First of all, that is indicative of healing the microbiome. That by itself is indicative of healing the microbiome. The form of the stool is the way in which a gastroenterologist assesses the microbiome in the same way that a cardiologist listens to a heart. And with that, not only do we have improvement of digestive symptoms, improvement of the bowel movements, but we also are seeing improvement of energy. I would not be surprised at all if she says that her mood has improved as well. And these are all markers of coming back to this root cause, which is the gut microbiome, which is connected to so many facets of human health, including our digestion, but also, as demonstrated in this case, our immune system. And then beyond that, our mood, our cognitive health, and our metabolism.
Excellent. Thank you. Dr. Sundermann, your thoughts, please.
Yeah, I was just going to comment on that same thing that Dr. B said. We know that, 90% of our serotonin is produced in the gut microbiome, about 50% of our dopamine. And so, the question is, Dr. Graff, is she able to get off the duloxetine? As that we know that could cause some loose stools. And if her mood is overall doing better, maybe that's something to look at titrating that down now that her gut microbiome, I think, is just absolutely fascinating. And when we get to some Q&A, Dr. B, I would like you to, I just went to a interesting webinar today about acromantia, and so want to get your input on, I know we're not talking about probiotic supplementation, but in healthy gut, if we can save that for the Q&A, if you could give some updates with that, be appreciated.
Great. Yeah, Dr. Breakey. Thank
Yeah,
you.
of course, the microbiome turns resistant starches and fiber into short-chain fatty acids, which not only nourish the colon and close the gap junctions, but get reabsorbed and are one of the strongest anti-inflammatory kind of components, also inducing satiety, going to the brain, helping us in chemical equations all over the body. Again, that's our key learning, is that she's increased her fiber from 5 or 10 grams a day up to at least a more reasonable amount. And as she's learned from that, that's where you can start to then say things like, the chicken, it may seem like a good source of protein, but it's actually 60-70% of the calories from fat now, the way they've obesified chickens. It's got no fiber. It contributes to pro-inflammatory. And so I know she likes it so far, and it's helped her make this transition. But as you're looking for next steps to do even better, getting away from that, and then continuing to increase the number of plants is your key. And as someone mentioned in the chat too, you can add a little oatmeal to your smoothie. I just put it right in there, and that's a way of adding some fiber and the avenanthramides that oatmeal has to offer.
Excellent.
Great.
Thank
Dr.
you.
Graff, had she tried any hummus or anything like that, where she would get a little bit of protein from garbanzo beans, but just in a different form?
She didn't, because she wasn't eating bread and she's not eating raw vegetables. And so I'm like, what? Like, you'd have
Okay.
to eat the hummus plain. So it didn't come up in my awareness
Yeah.
of things to kind of suggest to her.
Mm.
And I have to say, I'm sad because I saw her right before the last visit, right before I left working for Rochester Regional, and I wasn't allowed to take any of those patients with me. So I don't know what happened after this. She was really happy. I think she probably wasn't going to continue following with it because she felt like she was doing incredibly well. So I'm not sure whether she went on to see one of the other lifestyle medicine docs here or not. I don't have access to the records anymore. So, yeah, unfortunately.
Pretty remarkable and amazing, though, for a couple weeks.
Mhm.
Yeah.
No,
Yeah.
I kind of was trying to use a little bit about what you, Dr. B, what you put in your book, Fiber Fueled, but I was so worried about the strictures, kind of doing more of the liquefied stuff for her. So it was kind of like a half Brooke Goldner model of, she does like these hyper nourishing large green smoothies multiple times a day, and kind of your model of doing it. I kind of merged the two in my approach with her. And so I really appreciate that you felt okay about it, because I was like, well, you probably would have preferred I did like I just didn't feel comfortable putting her through like your 4-week plan of that
No,
progression. I would scare to death to do that with her.
Yeah. Not in structuring disease is very scary to me. And as you've seen with this patient, literally this patient, she had to have a small bowel resection because of her strictures. So, and it's the high fiber foods that are like specifically like greens and the skins on vegetables that are most likely to trigger that particular issue and cause an obstruction. You did the right thing. You did perfectly.
Thank you. I feel better, because I'm like, oh, I could get slammed on this case. And
Oh, hey.
my feeling is like, probably I would never have this woman eat a big salad, like a big raw salad. I would be scared to
I
death.
don't think I would either. I would be very
Okay.
cautious about it. And I would also, if I were to ease into those types of foods, not specifically like a big old salad, but even just greens that are not being super processed, meaning like either broken down in a blender or being really cooked to the point of being soft. Anything that I do that sort of pushes those boundaries, I would really sort of try to isolate it. I would moderate the dose of how much you're consuming in one meal, and then I would take a break and see how you respond. And because the big thing with this patient is if you start to have aggravation of symptoms or any discomfort, you got to go on a liquid diet.
Dr. B, do you think stricture can improve with decreased inflammation? I mean, we've seen coronary strictures resolving.
So, Bob, it's a good question. Strictures have two major components, and I've seen this throughout my career, and you see this during colonoscopy or endoscopy for people that have these. There's two components. There's the part that's inflammatory, and actually that can be the dominant part. And then there's the part that's actually scar tissue. And the scar tissue you can't get rid of. But what you can do is you can reduce the inflammation and the edema that's in that stricture from the inflammation. And that actually in many cases can be profound and dramatic. So like, for example, patients will be admitted to the hospital with a partial bowel obstruction from this type of condition. And if you put them on steroids, in many cases, it will resolve.
Mm-hmm. So I'm going to have to put a stop just for the moment because we have hit 8:30, but we are going to move into the lobby because we have a lot of good questions in the chat, a lot of interesting comments, I think, and a few more things to discuss. So, Dr. Graff, do you want to just finish with your learning points and then?
Let me just go through quickly. Number one, don't forget to look for other contributors to the diarrhea. Don't assume it's what the original diagnosis is. Two, diarrhea is going to flush out lactase that breaks down lactose and result in at least temporary lactose intolerance for about 48 hours after your last loose stool. All she had were loose stools, so she was constantly flushing this enzyme out. So even if that could recuperate when she's no longer having diarrhea, I still wouldn't recommend that she has dairy because of the inflammatory component, but it's certainly going to make the diarrhea worse. So avoid yeast and Crohn's, including nutritional yeast and beer. Avoid capsules or pills that don't dissolve in patients with bowel strictures because you don't want that stuff getting stuck there. Raw fruits and greens are incredibly anti-inflammatory and are often tolerated as long as they are blenderized. Just do the work for the gut so they'll move through. Greens are also typically tolerated when they're well cooked, but avoid raw in salad, at least initially, and maybe permanently if they got strictures. And increase consumption of foods that are whole food plant-based that are already tolerated before adding new foods, and then add new foods and gradually making sure they are in small pieces and well cooked or blenderized. So that is it for my case.
Perfect.
Great job, Dr. Graff. Thank you so much. And Dr. Graff, if you could just stop sharing.
Stop sharing.
All right, that's great. I just have one thing to share. And then we're going to move into the lobby here. Okay. So here's our just a little summary of what we have coming up. So there's a Jumpstart program information session on Wednesday, January 17th. If you're interested as a clinician for signing up for one of our Jumpstart programs, you can receive 10 CMEs. We, of course, encourage you to send your patients as well. We will send you a consultation letter if your patients join. And then we have program starts for February. We have one starting on Wednesday, January 31st, and another starting on Thursday, February 29th. The LIFT project, which is to elevate your mood, meets for an hour a week for 10 weeks. And again, healthcare professionals can receive 10 CMEs for attending that. And of course, we encourage you to send your patients. We have one beginning Sunday, January 21st, and another Monday, February 12th. And then we have health coaching. Individual coaching sessions start anytime. We have a group coaching program starting on Tuesday, January 23rd, dedicated to healthy and sustainable weight loss and optimizing nutrition. So with that, I will stop sharing. And I'm just going to wonder, is anybody, Dr. Friedman or or Deborah Chiali, have you got some questions that we would like to ask our guest panelists or panelists in general? And it looks like, while you're thinking about that, I have a question, which is that are there any disadvantages for people who don't have Crohn's disease? Are there disadvantages to using smoothies, or are smoothies just as good as chewing on the greens? Dr. Bulsiewicz, what do you think about that?
I'm a fan of smoothies, Ted. I don't know that I would classify them as being the same as chewing on the greens. I mean, you're really breaking it down quite a bit more than you would if you were to just chew it in your mouth and swallow it down.
Right.
But that being said, like particularly living in a world where, you know, many of us, we eat a healthful diet and we follow a whole food plant-based lifestyle, but like the average American right now is very similar to the first dietary assessment that we had on this patient, which is 10% plant-based. I mean, that's truly the
Mm.
standard American diet right there. And
Mm-hmm.
so if we can get more fiber and more phytonutrients into these patients using smoothies in the morning, which is so easy, anyone can do it. They can taste great. My kids love them. We do them as a family every day.
Mm-hmm.
Um, that to me is a great way for us to start to tackle this issue.
Yeah, I love that. Dr. Sundermann, your thoughts on that question?
I completely agree with Dr. B. I think sometimes what we might see is if people do juicing, we know that caloric intake of liquid, people can consume a lot more, right? So as opposed to if you have a couple of apples and strawberries and a banana and cherries, you're going to be really full in that volume, right? So, but if you juice it, you're intaking that, and people, they're trying to optimize their weight. Juicing may hinder that. So I think if you're looking at, let's just get fiber in, let's get eat the rainbow, then smoothies are an awesome option. But then when we're looking at intake, if people are trying to optimize their weight, we have to look at that juicing.
Thank you. Dr. Breakey.
Uh,
I see Willow.
Dr. Breakey, you're muted.
You're muted.
There we
Okay, sorry. I was saying since Dr. Bulsiewicz had his cat, I had to bring my my Bernie dog to say hello.
Let's get competitive here.
Um,
Right.
So there are, like a lot of things, pros and cons to smoothies, and I agree with in general the panelists that the pros tend to outweigh the cons. On the other side of it, two things. Obviously, it depends what you put in it, and not uncommonly people will add, agave or a bunch of sweeteners, artificial or otherwise, and make it kind of heavy sweet that has a high glycemic index because it's finely ground. The only other thing is that when you process something more into smaller pieces, that means more for you, but less for your microbiome. And Dr. Greger has a good segment on this on nuts. When you chew peanuts, you might get down to 1 millimeter size. When you make it into peanut butter, into kind of micron size, almost all of it gets absorbed and you get it, but your microbiome doesn't get the feast of what might be left over. We were taught in a digestive school that protein, carbs, and fats don't make it to the colon. Well, they do. When you eat whole, real foods, a certain amount of that does get through because it's small enough that it passes through, and that's part of the nourishment for your microbiome. So again, in this case, great to use smoothies. In Dr. Goldner's case, where people are dealing with severe autoimmune disease, you need hypernourishment. You need easy ways for people to make the transition. So again, don't get me wrong, fan of smoothies, but make sure that it's a lot of vegetables, not just fruit, and that you also eat real food. It's kind of like cooking. It brings out certain nutrients like lycopene in tomatoes. It may destroy others like vitamin C. So eat both. Have some smoothies and some real food.
Bob, I was just recalling when we had Brooke Goldner as a webinar. I think she was saying, she's a fan of the smoothies, but I think it's Dr. Esselstyn who is not.
That's right.
And so I think it was like, she said, Essie, you got to let me have my smoothies, and something about the chewing and releasing nitric oxide and things like that. So again, we're getting to minutia here, right? And when you're looking at the general lay public of just trying to increase intake, smoothies are good. But I remember that she said that Essie was like, no smoothies.
Really treating completely different patient populations, right? Dr. Esselstyn's treating these end stage cardiac patients,
right.
And Dr. Goldner's treating, bad autoimmune disease. So, Dr. B, I have a question for you about basically telling this woman to just cut all that out, all the gluten out based on the antibody testing that was done. Would you have insisted that she have biopsies as well?
Probably.
She did further get better, stopping it, but she also increased the diversity of what she was eating. So I don't really know which. She was convinced it was because she stopped eating gluten, and at that point she was off of it. But I was like, well, she really should have probably had the biopsy done. But by the time they got the biopsy done, then she's going to be off of it for how long?
Well, I mean, I think, this is an example of a person where you can make a compelling argument that it's so clear that you don't even need to actually go and do the biopsy because she has a brother who has celiac disease. So when you take that in combination with the fact that you have this positive serology, and then what I would do is I would put her on a gluten-free diet and then I would retest the serology and see where it goes. And the expectation is that it normalizes. And if that's the case, then you have demonstrated that this is legitimate, and also you have given yourself something that you can track going forward, which is nice. Because if she starts to have a flare-up of diarrhea again, you would immediately retest the serology to see if there's contamination in terms of gluten.
It's brilliant. I love that. Okay.
You have to be prepared for that because there's contamination everywhere, and many of these patients, they are trying to be gluten-free. They're doing their best, and they may not have access to someone who formally trains them on how to do this properly. And it's like they could put on lipstick and be exposed to gluten.
Mm-hmm. We do have somebody in the audience with their hand up. So Dr. Sarnowski Roberts, would you like to go live here and ask your question?
Yes, I would. Thank you. I want to take
Sure.
advantage of Dr. B being here. Totally unrelated, but I really enjoyed your book, Fiber Fueled. In fact, I ordered 7 copies to give for the holidays. Yes. But in your book, you mentioned the fact that the gut produces 50% of the dopamine that we have in our body. And I'm just wondering, in terms of patients with Parkinson's disease, is there any way we could take advantage of that in helping them with their disease?
Thank you, Sandra. First of all, thank you. You're amazing, and I'm grateful for your support. It's a little bit tricky because I don't want to make promises that the data can't back up or that I can't keep. But what I do know is this. There's evidence to suggest that you can detect Parkinson's disease in the gut before you can actually diagnose it based upon the clinical manifestations. So there's the belief that this is a brain-gut connection that actually is fueling this. Secondarily, people that have Parkinson's disease, they all are constipated. So part of this process, from my perspective, would be addressing the constipation, getting them into a proper bowel rhythm. And then once they're in a bowel rhythm, then there's an opportunity to actually enhance them from a dietary perspective using the strategies that we've discussed tonight. Because when you can improve, Bob mentioned the short chain fatty acids, which you know that I'm a huge fan of because you've read my book. And those short chain fatty acids have effects throughout the entire body, including the brain, including on executive function in the brain. And so do I know it's going to work? Do I have a study or an RCT to prove that? No, I do not. What's the risk? There is no risk. Treat the constipation, get that out of the way, then start to increase the fiber intake.
So somebody had asked you to speak about probiotics or prebiotics or in terms of that helping with constipation. Do you want to discuss that?
Constipation is a complex issue. It's a complex issue because it's not always slow transit. We have sort of assumed that it's slow transit. Actually, that's not the case. People can have pelvic floor issues that can contribute to constipation. So that's something to be aware of. Where do I like to start for the majority of my patients? I like to start with something that's simple and actually beneficial to their microbiome. So typically this is a combination of a prebiotic fiber supplement and magnesium. There's many different forms of magnesium. So typically magnesium sulfate, citrate, or oxide are the ones that I'll opt for. You can check a magnesium level before you start to make sure that it's okay. If this patient has a kidney issue, by the way, I don't do this, but check a magnesium level first, initiate the magnesium, get it to a steady state dose, have them pooping, and then recheck their magnesium level to make sure it's normal.
Great. Good discussion.
Which prebiotic do you recommend?
There are many choices. I don't know if you follow me online. I actually launched my own prebiotic literally yesterday. And I didn't come here to promote it. We actually sold out in 24 hours, but I did formulate this prebiotic because I always felt that there was a need that was not being met in the clinic. And I was not comfortable telling all my patients to go out and buy Benefiber which is wheat dextrin, because I don't know how that's been treated. I don't know if it's been sprayed with glyphosate or things like this. So I wanted to create something that I could have confidence in and also have it formulated based upon modern science. So anyway.
Excellent. Thank you for that, Dr. Sarnowski. Deborah Kelly or Dr. Friedman, have we got a question out there you want to promote? It looks like we actually had time for one question before we have to break here. By the way, for those of you who are on the call, you will be receiving at some point in the near future, you'll be receiving an email with a link. If you click on the link, it'll take you to a Google form. Fill out the Google form, answer some questions, and you will receive a CME certificate from the Rochester Academy of Medicine. And looks like we can get Melanie in here, and then we're going to have to call it a night. So go ahead, Melanie.
Great, thanks. Thank you, everybody, and thank you, Dr. Will. My question is about, you just said something about it. It's about eating whole grains. And do you always recommend that people eat only organic grains? And I've wondered that just because of glyphosate and other, chemical practices. In general, do you recommend always doing organic with grains?
I would rather people consume non-organic whole grains than not consume whole grains.
Yeah, hear you.
But I do have concerns about glyphosate, and I think that our process, or the way that our regulatory bodies work to approve certain things, like I'm appalled that they're not required to put on the label that the food was sprayed with glyphosate in the process of preparing it. Like, that's appalling to me. I don't understand that. And we know that this, glyphosate, for those who aren't familiar, this is Roundup. This is what you use to treat your yard and kill weeds. And we know it kills microbes. And so we don't need large, massive doses. You don't need to be drinking it. So exposure on a small level could potentially cause significant injury to the microbiome. And there are data to support that idea. And the problem is, like, what is the extent of the exposure in our food supply? And we simply don't know because we're not being told. They're not being tested. So I have these concerns. And I think that, to me, the way that I argue this is that I'm troubled by the fact that we take something that's completely unnatural, we approve it, we introduce it to the food supply, and then we have to somehow come up with overwhelming evidence to withdraw it. That's crazy to me. We should have overwhelming evidence to introduce it in the first place. It makes no sense. So, and I think that there's a lot in our food supply that is the case, but I think that this is one area where it's particularly profound. So, there are challenges here because not every person in America can eat organic all the time. So I think trying to have like a nuanced conversation around this is necessary, but I would certainly prefer organic.
Thank you for that. And I think that's a great note to end on. So I would like to thank Dr. Bulsiewicz, Dr. Graff for putting in all the work that you did. And our regular panelists, Dr. Sundermann and Dr. Breakey, and the people in the back office, Dr. Friedman and Deborah Chiali, and especially our engineer tonight, Robert Franke. So thank you all. Have a wonderful evening, and be on the lookout for that email so you can receive a CME. Good night, all.
And thank you, Ted.
My pleasure. Thank you all.
As
Bye-bye.
always.
Thank you.
Bye.
See you next
Good
month.
night, all.
Oh.